All right, we'll now review medical nutrition therapy for pulmonary disease. All right, so let's talk a little bit about pulmonary disease. So nutrition status and pulmonary function are interdependent. That is, well-nourished people breathe better, and people breathing better are typically better nourished. Now we do know so the type of fuel, be it carbohydrate, protein, or lipid, that an individual receives can affect physiological conditions and interfere with normal respiration. So if we feed people the right things, it's easier to breathe, and if we feed them the wrong things, it's harder to breathe. Now, malnutrition can evolve from pulmonary disorders and can contribute to pulmonary status. So again, going back to point one, which is they are interdependent. So if it's hard to breathe, you may become malnourished, and if you become malnourished, it'll be even harder to breathe than it was previously. Now taking a look at the anatomy and physiology of the respiratory system. So we do have the upper respiratory tract, which includes the nose, nasal cavity, frontal and maxillary sinuses, the larynx, and trachea. We have the lower respiratory system, which consists of the lungs, bronchi, and alveoli. And now as a quick review for the path of oxygen, so air enters the lungs through the trachea, which divides into the right and left bronchi, which supply the right and left lungs. The bronchi further divide into bronchioles, and the bronchioles end in small air sacs called alveoli. Each alveoli is embedded with millions of capillaries, which are responsible for the actual exchange of oxygen and carbon dioxide. So here you can see a zoomed in photo. And so again, realizing just how small capillaries are and how small alveoli are. Now looking at the development of the respiratory system, by age 10 to 12 years, the maximum number of alveoli is attained, with full maturation of the respiratory system being achieved at 20 years of age for female and 25 years of age for males. Now, unfortunately, we do know, similar to renal function, that lung function progressively declines with aging. That is, a decrease in the function and efficiency of your lungs will occur with aging. Again, though, there's the normal amount versus the amount that will occur during a disease process. Now, we'll also talk about throughout the lecture some supporting structures, which include the skeleton and the skeletal muscles. And so we'll talk about the diaphragm, and we'll talk about accessory muscles. But again, remember that these structures have to be anchored to something. So the lungs expand right within the chest cavity, so within the ribs, so as long as there's no deformity, etc. So again, these are not directly involved in respiration, but they do play a role. Now the actual gas exchange occurs in the alveoli capillary unit, and so the alveolar epithelium consists of two types of cells. So this is type 1, which form the structure of alveolar wall, and type 2 cells, which produce surfactant. Now what's important is, so a surfactant is a fluid secreted by the cells of the alveoli that reduces surface tension of pulmonary fluids and contributes to the elastic properties of pulmonary tissue. But that's surfactant in the biology world. You're actually familiar probably with surfactants when it comes to cleaning products. So very rarely nowadays do people actually clean their houses with soap. What you're actually cleaning with usually involves some amount of surfactant. And so most famous for this is window cleaner. So again, it reduces surface tension so that things spread out and can easily be wiped off of glass. So looking at the major functions of the lungs, so gas exchange is being the most well-known and major function. So here again we have the exchange of oxygen. We have this is used during cellular metabolism, and then we have CO2 is expired from the body. Now it also protects the body against infections and harmful environmental toxins. So this is inhaled particles such as smoke, bacteria, and viruses, which should pass through the nose and should be trapped in the lungs by mucus. And then we should have cilia should propel the mucus and unwanted cells upwards to be coughed up and expectorated, or to be swallowed, where again we know that the pH of the GI system will break them down, or the alveoli cells will engulf and destroy bacteria themselves. We know that the lungs do synthesize surfactant we talked about previously on the previous slide about type 2 cells. We know that it's involved in the regulation of the acid-base balance. So again, looking at the ratio of O2 and dissolved CO2 in the blood, the synthesis of arachidonic acid, and the conversion of angiotensin 1 to angiotensin 2. And so again, angiotensin converting enzyme is found mainly in the capillary beds of the lungs. So here you can see a zoomed in photo and an example of cilia with mucus, where again you can see dust and or bacteria will become trapped to either be consumed or to be expectorated from the lungs. And here again you can see the gas exchange with systemic circulation and pulmonary circulation. Again, remember that the blood actually has to be oxygenated before it is then pumped to the rest of the body. So looking at measures of pulmonary function, so again, how do we assess the lungs? So the four major components of the lung exam include inspection, palpation, percussion, and auscultation. So palpation is feeling, so again, feeling with the fingers or hands. Percussion is tapping on the surface with an instrument to determine the underlying structure. Again, the lungs should hopefully sound hollow. And auscultation, so listening to the lungs with a stethoscope. So things that can be detected with these methods include, for example, things like a pleural effusion, which is an accumulation of fluid between the two outer membranes surrounding the lungs. And so in essence, right, you have this pocket of fluid that may become larger and larger and actually cause the lungs to collapse, as again, because in essence that bubble is so big, it's now pushing on the lungs. You may hear rolls, which is a bubbling or crackling sound heard through the stethoscope. This can occur during inflammation or large amounts of mucus, or if water is in the lungs, and so again, this would be from non-compliance. And this is why it's called congestive heart failure, as you may hear someone will sound congested, right? And what you're hearing is that fluid, right? But instead it's from the heart, and it's now ending up in the lungs. We can also monitor pulmonary function with a pulse oximeter. This uses light waves to measure the oxygenation of arterial blood by detecting the percentage of oxygen within the hemoglobin molecules based on the color of the blood. And so, of course, depending on the size of the patient, the finger, toe, or earlobe can be used. So this is done at the bedside. It's pretty routine monitoring nowadays. Again, normal is 95 to 99%, and anything less than 95% is considered hypoxia or low oxygen. Now you'll see that in the photo, of course, it's using a reusable, it's a rubber sensor. But nowadays what you'll see is this is often, it's literally just a small sensor in a paper bandage. So it goes over your fingertip and kind of wraps around it the same way they would if you had a cut, if you were working in a restaurant. It's like one of those special fingertip bandages. And so now most of these materials are disposable just in case of possible contamination. And so you can see on this slide a much older pulse oximeter. You may see these though, they may have the wireless version of these when they check your vitals, which is just part of routine vitals when you go to the physician for your standard, any visit really, but your annual checkup. Another way to measure pulmonary function, you may be familiar with this device or you may have seen one and not known what it's for. It's known as a spirometer. And so this is the most common test done, so in which case the patient breathes into a tube that's attached to this device, and this calculates the amount of air that the lungs are holding and the rate at which air can be inhaled and exhaled. Now there's actually different ways to use a spirometer, or you also probably have seen what's known as a peak flow meter. And so what we're actually measuring is a couple different measurements. So one of those, for example, is forced vital capacity. And so this is the total volume of air expired after a full inspiration. So you breathe in as much as you can, and you breathe out as much air as you can. And so here we're looking at, so for example, if there's a buildup of scar tissue, the lungs may not expand properly. And we also have FEV1, or forced expiratory volume in 1 second. So this is the volume of air exhaled in the first second after a deep inhalation. So again, not only can you exhale the air, but can you forcibly, exhale it from the lungs. We can also monitor ABGs, or arterial blood gases. From here we can determine pH, oxygen content, and the CO2 content of blood. And so, for example, one thing that will be a running theme throughout this lecture is we'll talk about is PCO2. And so this measures how well CO2 is able to move out of the blood and into the air spaces of the lungs, and then out with exhaled air. We have PO2, which is how well oxygen is able to move from the air into the lungs. We have oxygen saturation, which measures the amount of oxygen carried by red blood cells. So obviously this will be decreased in forms of pulmonary disease. And pH, which measures the hydrogen ion concentration in the blood. And so remember that PCO2 and pH are going to be related, as again, CO2 is dissolved in the blood in the form of carbonic acid. So respiratory systems respond quickly to acid-base disturbance, and this is seen in what's known as minute ventilation. And so minute ventilation is the volume of air per unit time moved into or out of the lungs. And so this is measured by collecting expired volume during a fixed time, for example, 1 minute. So again, what you'll see is, and you'll see this on patients, for example, that are on ventilator machines, in which case the pulmonologist has evaluated this patient and is actually setting how much volume and how quickly this patient's going to breathe. So you'll actually have the respirations, which is how many times you're going to breathe in a minute, and then how much air, which is actually the minute ventilation, how much air is actually going to go in and out of the patient's lungs in that 1 minute. So for example, if acidosis is occurring, respiratory activity is increased, and the lungs will compensate to remove the CO2. Remember that carbonic acid. So if you're too acidic, the body will compensate by removing acid or blowing off CO2. If alkalosis is occurring, respiratory activity will actually decrease, retaining CO2 and contributing more carbonic acid to the blood. Other tests can include sputum cultures, which are always one that I run and hide from when they're collecting, because it's just what you imagine, which is basically we need to cough up the nasty junk into this cup, which is then sent off for testing. Biopsies of lung tissue and imaging procedures, but most commonly, you'll probably see what's known as a chest x-ray. And so some of you may even need to get this depending on your vaccination history, your titer history. And what it is again, we can take an x-ray of the lungs, which should show up as a nice clear blank space on the x-ray. But if there are infiltrates, or if there's what's known as ground glass, or it looks kind of like an air filter where you can kind of see the cobwebs in the bottom of someone's lungs, that's not good. So taking a look at nutrition and lung health. So protein energy malnutrition does impact lung function. So this can affect the strength and endurance of respiratory muscles. This can cause a reduction in lung parenchyma, which is the functioning tissue, alveoli, bronchioles, and capillaries, and can contribute to pulmonary infection. Signs and symptoms of pulmonary disease include early satiety, poor appetite, weight loss, cough, and dyspnea during eating. Smoking is associated with reduced levels of antioxidants in the body, and cigarette smoke causes injury and inflammation to the lungs, and long-term increases the risk of lung cancer. Now there's some interesting stats, and so we'll talk about lung cancer and smoking, but for example, the chances that you actually develop lung cancer from smoking is only about 10%, which based on the commercials and advertisements, you would think everyone who smokes gets lung cancer. Now the problem is this data is actually highly skewed, and so we'll talk about this, but what happens is that smoking also causes other changes in the cardiovascular system. And so what happens is the patients actually die from something else before they would get lung cancer. So they may die from a heart attack, a stroke, etc. Had they lived longer, they would have gotten lung cancer, but that's why you'll actually see, and so it's one of those very strange statistics, which is not that many smokers actually develop lung cancer. All right, so we'll take a look at our first disease, which is asthma. So here we have a chronic disorder of bronchial hyperresponsiveness. So this is characterized by increased mucus secretion causing obstruction, inflammation and swelling, the smooth muscle tightening resulting in smaller airways. So asthma has actually increased since the 1980s and is the third leading cause of hospitalization and chronic illness in children under the age of 15. So it'd be severe asthma. So what causes asthma? And so we're not entirely sure. We see there's genetic factors, in which case if you have a family history of asthma, you're more likely to develop. Could also be immunological. And so part of this is what's known as the hygiene hypothesis, which is we're so clean now that we actually have a hyper response to allergens. And environmental factors, including exposure, the climate that you live in, etc. Now we do have allergic asthma, or extrinsic. So this is triggered by inhaled outdoor allergens, such as dust mites, pet dander, pollen, and mold. And we have non-allergic asthma, or intrinsic. This is triggered by anxiety, stress, exercise, cold air, dry air, smoke, viruses, and hyperventilation. Now there is an association between asthma and obesity, with weight loss resulting in an improvement in the symptoms of asthma. So what do we see with asthma? We see bronchoconstriction. So the smooth muscle contractions of bronchi and bronchioles in response to a stimulus or allergen. The mucosa become inflamed and edematous with the increased production of mucus. And an increase in mucus can cause partial or total obstruction of the airway. Clinical manifestations include recurrent episodes of coughing, wheezing, breathlessness, and chest tightness, increased respiratory rate and labored breathing, tachycardia, and if prolonged, can progress to respiratory alkalosis due to shortness of breath, and can lead to compensatory respiratory acidosis. So the treatment for this, as I'm sure you've seen in many movies, is we need the immediate need to dilate the airway and improve oxygenation. And so we do this with bronchodilators, which you've probably seen what's known as a rescue inhaler. So again, this is a type of steroid, so most famously albuterol, which is going to ease the symptoms, the wheezing, coughing, and tightness of the chest. Now we also have some long-term steroid options, so this is chronic steroid therapy and is a different type. And so you may have seen these are things like prednisone, formoterol. There's some other medications that are being used, which again will not treat the acute attacks, but are for long-term management. Environmental trigger control. So if you're allergic to cats, don't purchase a cat. If you're allergic, for example, to grass, they recommended that people move out west. Now the problem is that people in Arizona have wanted to turn it into the eastern seaboard, and they've now actually planted so much grass that those recommendations don't actually work like they used to. But so, for example, if you were allergic to certain plants, then one option would be to move and not be near them. Obviously, if you're allergic, for example, to something like mold, no one should live in a moldy house. That's other issues. But if it's something that you can avoid, for example, if you're allergic to a dog, don't buy a dog. If you're allergic to a cat, don't buy a cat. If you're allergic, for example, to pine trees, don't bring a Christmas tree in the house. You should get an artificial tree, etc. Other things that can help, again, remember some asthma is related to anxiety, so again, controlled breathing techniques to maximize oxygenation. But again, we're usually going to need a pharmacological intervention. Now, other things that we notice is that the increase in asthma parallels obesity rates. So again, here we have interesting correlation, not necessarily causation, right? Obesity doesn't cause you to develop asthma. But again, these are all things that have dramatically increased since the 80s. Other things that we see is, so there's a protective effect of breastfeeding, which is early breastfeeding for the first year of life actually reduces the risk of asthma. There's some evidence to suggest that omega-3s may decrease the production of leukotrienes. And so these leukotrienes are chemical mediators synthesized from arachidonic acid, as you remember, something that's synthesized in the lungs and contributes to the development of asthma. So it would make sense that something that is pro-inflammatory, something that is anti-inflammatory like omega-3s, would then decrease its effect or production. Vitamin C may modify oxidative insult or stress from inhaled or infectious agents and reduce cellular inflammation. So the strongest data supports vitamin C compared to your other antioxidants, which would be your A and E. So vitamin C does seem to be the most prominent for the treatment of asthma. Now, caffeine also acts as a bronchodilator. Now, again, I'm not saying that this would be a substitution, but it is something of note. You may have seen the Jodie Foster movie Panic Room, in which case they are giving the child caffeine in the form of coffee, but caffeine actually does act as a bronchodilator. Again, I would not recommend those substituting it for medical treatment. Now, there is no cause and effect relationship between consuming milk products and an increase in mucus production in asthma. Now, what you will notice, though, is that the proteins in dairy will bind with mucus, making it much more noticeable, but it doesn't actually increase the total amount of mucus that is produced. Removing known triggers, again, for example, checking your house for mold, not bringing, for example, live plants into the house. Again, if it's a pet, right, either avoiding or removing that pet from the home, etc. And many asthma medications have nutritional side effects, including dry mouth, nausea, vomiting, diarrhea, throat irritation. These are obviously the inhaled medications which are most likely to irritate the mouth and throat. Long-term steroids, specifically prednisone and corticosteroids, again associated with that increased blood glucose, sodium retention with blood pressure issues, and changes in bone mineral density. Again, because of the increased appetite from steroids, we're concerned about weight control, but again, our actual recommendation is just a nutritionally adequate diet. So as long as they're not overeating and they're getting adequate nourishment and micronutrients, they should be fine. The second disease we'll discuss is bronchopulmonary dysplasia, or BPD. So it's characterized by pulmonary inflammation and impaired growth and development of the alveoli, and this occurs due to incomplete recovery from lung injury during the neonatal period, and immature lungs that cannot synthesize surfactant. So this is also referred to as chronic lung disease of prematurity, and risk factors include prematurity and/or low birth weight, perinatal infection, meconium aspiration, and tracheoesophageal fistula. Now, what causes this? So again, we know that genetics plays a role in susceptibility. 20 to 40% of patients born prior to 28 weeks gestation and weighing less than 1,000 grams, aka 2.2 pounds, will develop BPD. We also see that prolonged exposure to high oxygen concentrations due to supplemental oxygen. So it's kind of a catch-22, which is if you're born premature, you need an oxygen-rich environment to get enough oxygen, but being exposed to that high oxygen environment increases the risk that you develop BPD. Now, what you may see is that depending on if it's an emergency or if it's a planned C-section and we know the baby's going to be premature, is, again, we'll talk more about this in MN Nutrition Disease 2 when we take a look at premature infants. And what you'll see is that sometimes it does become a matter of days or weeks in which case we may also give mom steroids to increase the growth of the lungs to help reduce the risk of this BPD after birth. We're also at risk for oxygen free radical damage due to poorly developed antioxidant system in premature infants, and poor vitamin A status, again looking at the antioxidant system, may be a possible factor in the development of BPD. Signs and symptoms include hypercapnia, tachypnea, wheezing, dyspnea, recurrent respiratory infections, cor pulmonale, which is a right ventricular enlargement, and heart failure, so it's a specific pattern. And the treatment is a prolonged intensive hospitalization with mechanical ventilation, parenteral and enteral nutrition support. So again, this is either going to be a feeding tube or IV nutrition, as the patient will have a breathing tube inserted. And again, we talk about the use of prenatal steroids if we suspect premature delivery. From a nutrition standpoint, things that we're monitoring or worried about is that the patient may often have poor swallowing function, oral aversion, reflux esophagitis, and fatigue during feeding. And so again, what happens is that because the breathing tube has been in for so long, is that it may actually be difficult to swallow or coordinate the muscles, as they've had to lose tone and relax to accommodate the intubation. Again, because they've had something in their mouth and in their throat for so long, the patient may not want to eat, etc. And of course, we're usually looking at this with infants. Growth failure due to decreased nutrient intake, increased needs, hypoxemia, delayed skeletal mineralization and osteopenia, increased energy requirements due to the increased work of breathing with an increase in resting metabolic rate. And again, things we're going to be monitoring is weight, length, and head circumference. And again, we'll talk about with prematurity how that's calculated in nutrition and disease too. And so here you can see some of the components to be assessed or things to consider. Again, this is in those neonates with BPD. So what we're looking at is that energy needs may be 25 to 50% higher than age-matched controls, and they may require 120 to 130 calories per kilogram per day. And as you'll recall, right, your standard is going to be 108 calories per kilogram per day. For protein, monitoring labs closely, as the immature kidneys cannot handle high protein loads, with about 8 to 12% of total calories coming from protein. So these patients have a very high amount of protein grams per kilogram at 3 to 4 grams per kilogram. But again, if the baby only weighs 2 kilograms, that's only 8 grams a day. So a very high relative amount, but a very low absolute or total amount of protein. And we'll talk more about carbohydrates with lung disease going forward, but again, increased carbohydrates increases RQ, or increases the risk for developing an out-of-regulated RQ. So why are energy needs increased for BPD? So we have an increase in basal metabolic rate, increased effort of breathing. So again, because it's not very effective, they're now struggling and actually working harder to breathe. Chronic hypoxia or low oxygen, chronic illness and other infections, which again increases metabolic rate, respiratory distress and metabolic complications, tissue repair and catch-up growth. So in addition to the additional calories needed for the disease process itself, because this is most often seen in premature infants, we also have the increased calorie needs for catch-up growth, which again will be discussed in nutrition and disease too. And drug-nutrient interactions. So things to consider, so vitamins and minerals. So vitamin A, a supplement of 1,500 to 2,800 international units per kilogram per day in low birth weight infants, has led to decreased incidence of BPD, decreased number of days on vent, and the decreased number of days in the ICU. Iron we know is important to maximize tissue oxygenation and minimize oxygen consumption. Keeping a close eye on electrolyte balance and fluid status, and sufficient minerals for bone growth. Again, this premature population is at risk for osteopenia with inadequate bone mineralization. Feeding practices, early aggressive nutrition support with transition to bolus feeds. We'll talk about, so breast milk plus human milk fortifier is preferred to reduce the risk of sepsis and necrotizing enterocolitis. So again, we talked about that in addition to the needs for this disease process, there are secondary illnesses that may occur. And there are specialty premature infant formulas with higher calorie concentrations at up to 24 calories per ounce and even higher if necessary. So again, these can provide carbs, protein, and fat. It can be done as modulars or additives. So again, ensuring that we're hitting that 3 to 4 grams per kilogram for protein, while also hitting the appropriate total amount of calories. Again, with monitoring and controlling protein first. May need fluid and sodium restriction, and again, significant education support to caregivers. So again, understanding how to treat this, how to prepare the formula, how long they're going to be on this formula before it's changed, etc. And so here you can see a gastrostomy feed. And so again, so these patients may be on feeding tubes for a significant portion of their infancy. And so again, this will require significant education of the family, which will be done by nursing and dietitians. All right, so we'll move into chronic obstructive pulmonary disease, or COPD. So this slow progressive disease which limits airflow through either A, inflammation of the lining of the bronchial tubes, known as bronchitis, or B, destruction of the alveoli, which is emphysema, or a patient may have both conditions. So COPD is the fourth leading cause of death in the US, and the primary risk factor for the development of COPD is smoking. Other risk factors include air pollution, secondhand smoke, a history of childhood infections, occupational exposure to industrial pollutants, and genetic risk. So emphysema, or type 1 COPD, is characterized by abnormal, permanent enlargement and destruction of the alveoli. Now, this does develop gradually over a period of time. So again, this is a disease that gets worse and worse, and so due to inflammation causing oxidative stress. In rare cases, emphysema is due to a deficiency of a protein called alpha-1 antitrypsin, or ATT. So ATT is produced by the liver and travels to the lungs to protect them from destructive actions of common illnesses and exposures, particularly tobacco smoke. Now, this occurs in 5% of cases in the US, right, are going to be attributed to ATT deficiency. Again, so most of the time this is due to lifestyle choices or work exposure, etc. Now, in essence, though, as dangerous as tobacco smoke is, right, then when you're ATT deficient, even secondhand smoke becomes incredibly dangerous. And so this can actually occur at a young age and even without exposure to tobacco smoke. Chronic bronchitis, or type 2 COPD, characterized by a persistent productive cough with inflammation of the bronchi and other lung changes. So here we have a productive cough, which means mucus or junk is coming up, and shortness of breath that lasts 3 months each year for 2 or more years in a row. And again, the primary cause of chronic bronchitis is smoking. Clinical manifestations include decreased airflow rates, so this is that decreased forced expiratory volume, dyspnea, hypoxemia, and hypercapnia. Signs of low oxygen include cyanosis, clubbing, and secondary polycythemia. And so as this disease progresses, quality of life decreases, malnutrition is common. And so what you're probably most familiar with when you've seen chronic bronchitis is you'll see patients that use supplemental oxygen with a nasal cannula, in which case this is the plastic tube that inserts into the nostrils, and you'll see they drape this over their ears, and the patient has to either carry around an oxygen concentrator or oxygen in a tank. And so again, that's for the treatment of the COPD. So what happens is we actually just give you air that has more total oxygen in it to make it easier for your body to absorb. Cardiac complications include cor pulmonale and left ventricular failure. Here you can see an example of cyanosis. So this is why I chuckled when I saw that many people were putting, for their medical terminology, they were putting greenish. And I understand that's what the book said, but remember that cyan. So when you're looking at your printer colors, you have magenta, cyan, and yellow, aka you have pinkish purple, blue, and yellow. And so cyan or cyanosis is somebody's extremities or fingertips will begin to turn blue. The pathophysiology for emphysema. So again, destruction of actual lung tissue occurs, which results in a loss of surface area and decreased amounts of surfactant. Bronchioles lose elasticity and collapse during exhalation, trapping air in the lungs. Clinical manifestations for emphysema include decreased FEV, dyspnea, and orthopnea. And so the term that is probably new to you is orthopnea, which is difficulty breathing while lying down. And you may see in the patient's chart 1, 2, or 3 pillow orthopnea, which means that is the number of pillows they need to help them sit up so they can comfortably breathe. It's also not unusual for this patient population to sleep in a recliner and to sleep sitting upright to assist them with breathing. So again, the more upright they're sitting, the worse the condition. You will also see the development of quote-unquote barrel chest. And so here what you'll see is what's known as the serratus muscles, which again, these are usually typically only seen if they're excessively hypertrophied or if an individual is very, very lean. But so again, these look like the rib muscles close to your armpit, the rib muscles on top of your rib muscles. And so what you'll see is that these muscles will become well developed as these patients are using skeletal muscle to help them breathe, when they should only be using the diaphragm. And so what you'll see is extreme fatigue and exhaustion preventing oxygen intake in late stages, resulting in hypoxemia. Treatment for COPD includes lifestyle changes, such as smoking cessation, avoiding smoke, and avoidance of other pollutants. And while it may be difficult to exercise, we actually want these patients to exercise as tolerated. So again, they actually need to be participating in exercise, although it may seem counterindicated as it is difficult for them to exercise. So it may be very low intensity, or what we would consider low intensity. Good nutrition, pharmacological treatments to prevent and control symptoms, including steroids and bronchodilators. You may have seen these drugs, they're commonly advertised. I think the most common one right now is formoterol, in which case you'll see it has an old man, and it has then the cartoon drawing the old man as though he is the wolf from The Wolf and the Three Little Pigs, and then basically he can't blow the house down because his lungs are so weak. So pulmonary rehabilitation is similar to cardiac rehab, so a multidisciplinary approach with therapeutic exercise, which is going back to that exercise as tolerated. We want to increase exercise tolerance. But basically, if you ever wondered what can I actually do with a degree in exercise science, that's what you're really doing, is you're going to monitor patients like this in a clinical setting. And in essence, it's clinically dosed exercise to increase their tolerance. And typically it's going to be to cardiovascular activity or endurance exercise. Again, malnutrition is very common, so something they're going to be screened for. So an assessment to identify patients that are at risk, including a measurement of anthropometrics. So we're going to be monitoring weight loss and low BMI, as these are increased mortality in patients with COPD. So patients with COPD who have lost weight or have a low BMI are an increased risk of death.
Now again, we also may see a depletion of lean body mass even though they have a normal body weight. And again, this is determined, and we can assess this with tricep skin fold and then turning that into our arm muscle area. We want to take a look at their food nutrition related history, medication use, being aware of any interactions, and again looking at their physical activity level and their physically functioning level. So again, are they able to prepare their own meals? Are they able to take care of their own house? Are they able to do their own grocery shopping, their ADLs, etc., etc.? So again, looking at our intervention, if we had indirect calorimetry, that would be ideal. So again, looking at being actually able to measure, because again, if we're looking at oxygen exchange being how we determine people's metabolisms with indirect calorimetry, and oxygen exchange is what's impaired in these patients, then that's what we would want to monitor to get the best estimate of their caloric needs. Now, if we're using formulas, we know that their energy needs are about 125 to 156% above basal, with an average of 140. So again, it's like using a resting energy expenditure times our activity factor is going to be 1.4. Now again, we do want to avoid excessive calories, and we'll talk about how a little bit further down how overfeeding increases our CO2 production. Protein is going to be about 15 to 20% of total calories, or about 1.2 to 1.7 grams per kilogram. Carbohydrates are going to be 40 to 55% of the diet, and fat 30 to 45%. So what we see is an increase in fat intake and a decrease in carbohydrate intake. The reason for that is that overfeeding of total calories or overfeeding of carbohydrates is a concern, as it leads to an increase in CO2 production, which can complicate breathing or ventilation. So a glucose administration of greater than 0.5 milligrams per kilogram per minute increases CO2 production and can make it more difficult to wean a patient off of their breathing machine. In which case, right, we'll discuss this more as we discuss TPN and what those numbers look like. But in essence, it's a relatively very low carbohydrate diet when we're trying to get somebody off of a breathing machine. Other nutrients of concern include phosphate. So this is respiratory and peripheral muscle stores of phosphate will become depleted during COPD. And phosphate is essential for the synthesis of ATP and 2,3-diphosphoglycerate, or DPG, both of which are essential for pulmonary function. So we do monitor phosphate levels in individuals with pulmonary disease or respiratory failure. And again, we know that certain medications, including corticosteroids, bronchodilators, and diuretics, are associated with hypophosphatemia. Other interventions include small, frequent meals, calorically dense foods that have been fortified, or supplements. And so again, a common example, for example, if somebody would normally eat pretzels or potato chips, which are high in carbohydrate, you would want to have them switch to something like peanuts, where again, it's going to be higher in fat, lower in carbohydrate, but very calorically dense. There are commercial formulas that are low carbohydrate, approximately 30%, and high fat, approximately 50%, again, due to the fact that carbohydrate metabolism yields the largest amount of CO2 and fat yields the least. One of these is Pulmacare, and so that is an Abbott product, which is 28.2% carbohydrate and 55.1% of calories from lipids. Now again, as we discussed previously, is that physical exercise should be a part of rehab to help strengthen respiratory muscles. Here we can see a table. So again, using the EAL to plan nutrition interventions for patients with COPD. So again, looking at how we choose specific foods, and again, general guidelines of high calorie, high protein, and higher fat supplements. Again, I gave you one example, but in essence, that's kind of what we're doing throughout the diet, is finding substitutions that are going to be lower in carbs and higher in fat, again, to increase total calories and energy density while decreasing carbohydrate intake. So we'll move into our next disease, which is cystic fibrosis. So this is characterized by an abnormally thick mucus secretion from epithelial surfaces of various organ systems, including the respiratory tract, GI, liver, genitourinary system, and sweat glands. This is caused by an abnormal cystic fibrosis transmembrane, or CFTR protein, and so this is a mutation that causes cystic fibrosis, or this production of this excessively thick mucus. This is the most common autosomal recessive disorder in the United States. So again, remember that when we look at a single nucleotide polymorphism, that is your big B, little b, is the big B is dominant, little b is recessive. This would require both of your parents to be the carrier, and then you would then actually have the disease. So the incidence is 1 in 3,500 live births. This is usually diagnosed by age 3, but numbers of individuals being diagnosed later in life is increasing. So again, we're noticing the symptoms, or they may not be as severe until later in life. 1 in 31 Americans are carriers. Again, because this is recessive, this requires both parents to be carriers or have the disease. If one of your parents is not a carrier, then there is no way to inherit this mutation. There are approximately 30,000 children and adults in the US with cystic fibrosis, and the median age of survival is 37 years. So again, the reason why we use median and not mean is there are some outliers that will skew this, so some people can live much longer lives, but some people do have very short lifespans due to this illness. Here you can see an example. So we have two carriers, and their genes are large R dominant and small r recessive, as in both male and female. Now when we do the math, we have one child will not be a carrier and will have dominant. Two children, or two possibilities, would be a carrier but not expressing cystic fibrosis, which would be one dominant, one recessive. And there's a 25% chance, or one of the four you'll see is recessive, and would be affected and have cystic fibrosis. So thick viscous secretions due to the CFTR mutation. Again, this leads to obstruction of glands and ducts with chronic respiratory symptoms and pancreatic insufficiency. And so a blocking of the pancreatic ducts prevents the secretion of amylase, lipase, protease, and bicarbonate. It also causes a form of diabetes, with 10 to 15% of adults with cystic fibrosis having a form of diabetes, again, due to an inability to successfully secrete the insulin because of the blocked ducts. Cirrhosis of the liver with portal hypertension is common, again, because of the thick secretions, and dehydration with increased sodium and chloride in the sweat, leading to electrolyte imbalances. The diagnosis for this is we do a sweat chloride test, and then we can do a blood test to actually examine the CFTR gene to examine it for mutation. Sputum cultures are collected to look for secondary infections, pancreatic function and pulmonary function tests to assess the damage. Again, there is a DNA test to determine if you're a carrier, if you have, well, I say if the patient is being tested, they're obviously a carrier, they're affected by the illness. But there's a test for preliminary or prophylactic testing. So again, you could see if you and your partner, right, had this gene, etc. Because of the decrease in lipase, we have low levels of fat-soluble vitamins, and we may have difficulty digesting fat, leading to steatorrhea. Treatments include aerosols or inhaled bronchodilators and mucolytics to help break down the mucus, anti-inflammatory meds due to inflammation in the lungs, antibiotics for any secondary infections, and chest physiotherapy. Previously, this was done manually with a technique known as cupping, and this is not the cupping that you see with the suction cups on the back, but actually you would shape your hand like a curved C, and you would actually you would work the back, someone's back, to actually knock the mucus loose, and then they would expectorate or cough the mucus up. This is now being replaced, though, by, in essence, there are strap-on vests that basically mimic this therapy. Pancreatic enzymes are commonly used, or PERT therapy, so pancreatic enzyme replacement therapy, again to help with digestion and micronutrient absorption. And again, the long-term treatment plan is a lung transplant. So again, our nutrition implications are poor digestion, absorption, and malnutrition due to dysfunction in the pancreas, especially focusing on the fat and fat-soluble vitamins, abnormal growth due to poor intake and increased needs, an increased risk of osteopenia and osteoporosis, again with lifelong use of prednisone, and malabsorption of calcium, vitamin D, and phosphorus. Things to monitor in our anthropometric measurements, again, is that early detection of poor growth allows for interventions and better outcomes. Again, looking at laboratory tests for looking at vitamin levels of A, D, E, and K. And possible diagnoses include increased nutrient needs, inadequate energy intake, altered GI function, and underweight. Here you can see assessment of nutrition status for individuals with cystic fibrosis, and it gives a timeline for how often these measurements should be taken. So again, when we're measuring weight, height, and head circumference, this is in a juvenile. And again, you'll see mid-arm, tricep skin fold, and arm muscle area annually, which can also still be measured in an adult. And again, you can see laboratory data for micronutrients, as well as a 24-hour recall and nutrition supplement intake, which again is just done at a yearly follow-up. Some notes about pancreatic enzyme therapy. So this is taken with food or beverages. Again, so these are supplemental enzymes that are coated, so the capsule they are in will survive the digestive tract. These enzymes will then reach the duodenum and actually increase digestion and absorption. Energy needs in these patients is somewhere between 100 to 110% higher, and maybe up to 200% higher. So in essence, for some of them it may be the same. For some it's a 10% increase, but anywhere from 10 to basically 100% or doubling their caloric needs. Again, we recommend a higher fat diet, and we may possibly recommend MCTs, again, as these require less lipase and less bile salts for proper digestion and absorption. These may lead to improved tolerance in this patient population. And protein, approximately 15 to 20% of total calories. Other supplements, so the fat-soluble vitamins should be supplemented in a liquid, chewable, or tablet form. Calcium, and a relatively high salt diet due to excessive losses through the sweat. Recommended infant feeding, so we recommend breastfeeding until the first year, then switching to whole milk, and infant formulas. Again, may need to concentrate or fortify breast milk to reach higher calorie levels, while still promoting high calorie, high fat foods. Supplements may be helpful, or we may need to use what's known as nocturnal feeds. So when we discuss enteral feeds next week, in essence, a nocturnal feed is that the child would eat normally during the day, but then still have a feeding tube that they use while they're sleeping to increase their total calorie intake for the day. We'll move on and take a look at lung cancer. So the primary site is in the bronchi. And so you may be familiar with, again, similar to the liver, the lung is actually divided into lobes. And so you'll have 5 lobes, and you actually don't need all of your lung to still breathe. Now, again, it will be affected, but the problem is that the primary site is actually in the branches themselves, which would require the entire lung to be removed. Sometimes, depending on the location of the tumor, it can be removed and cut off of the lung, but if it's in the bronchi, this is not the typical option. Frequent metastases to the bone, brain, liver, or skin. Again, often associated with tobacco smoking, so for those that were lifelong smokers that live this long, it's very common, but again, only about 10% of smokers develop lung cancer, as they usually die from some other cardiovascular disease before developing lung cancer. Treatments include radiation, chemotherapy, and surgery. Signs and symptoms of lung cancer, though, include shortness of breath, pain, indigestion, and weight loss. And again, there is a famous trial, and so I would make sure that you know this both for life and for the RD exam, in which high-dose beta-carotene had a negative effect. So what we saw, and it would make sense, is that smoking is oxidative stress. So if we took supplements that were antioxidants, would it protect us from smoking? So they gave people vitamin C, beta-carotene, etc. And beta-carotene was found to be incredibly dangerous, and the study was actually stopped prior to completion because it had such a demonstrative effect on increased risk. Now we do know that increased fruits and vegetables are beneficial, and that calorically dense supplements and total calories are beneficial during treatment. So taking a look at our next disease, and again, it has so many causes, so I hesitate to say disease, but again, we'll be talking about pneumonia. So this is an inflammation of the lungs that can be caused by bacteria, viruses, fungi, or as a consequence of aspiration of food, liquid, or secretions. So it's the fourth leading cause of death in the elderly, and prior to 1936, pneumonia was the leading cause of death. Now you'll notice that 1936 was prior to World War II, and with the onset of the war and leading up into the war, we might have invented, you guessed it, antibiotics. So with antibiotics, it's much easier to treat bacterial pneumonia. Again, the problem is that this does not solve the problem of viral pneumonia, which is why we're at home right now, is that one of the complications of the COVID-19 virus is that it causes pneumonia. And for many of the elderly, which is where we've seen this increased risk of death, and this is what requires the hospitalization of so many elderly with the COVID-19. Now, though, with antibiotics, it's the eighth leading cause of death. So again, this is why you may have recalled the Z-Pak or azithromycin. Again, is an effective treatment for pneumonia, and again, it was once considered a very strong antibiotic for the treatment of pneumonia. So here we have, microorganisms of some kind enter the lungs, or the normal lung defense mechanisms are compromised, such as the elderly, infants, and children, those with chemotherapy, organ transplants, or HIV or AIDS. And so there are two different types. There's community acquired, in which case an infected person coughs or sneezes and spreads the bacteria or virus to those around them, or hospital acquired or nosocomial pneumonia, or healthcare associated pneumonia, and this often affects patients on vents or in the ICU. You will also hear about aspiration pneumonia. And so you've all aspirated at some point in your life, but you were young and healthy, so it had no lasting effect. But if you've ever had something go, quote unquote, down the wrong pipe, and you are coughing and sputtering for long periods of time, and you may notice that if something goes down the wrong pipe, quote unquote, that you are then coughing for up to an hour later. That's a very, very strong cough reflex, and that's actually your lungs protecting you from developing pneumonia. Now, in the elderly or those with compromised systems, is that this food or fluid may get into their lungs. This can include saliva, nasal secretions, bacteria, liquids, foods, etc. And then this can cause a form of pneumonia known as aspiration pneumonia. You will also see that this notes gastric contents or vomit. So again, this is why, depending on how much you've imbibed alcohol in your youth, you may be aware of, quote unquote, the safety position, which is if someone becomes so intoxicated that they go unconscious or black out, that you need to place them on their side to ensure that they, quote unquote, do not choke on their own vomit. And actually the concern is that they will, quote unquote, aspirate, is what they're actually doing. And they would develop pneumonia and die. So aspiration pneumonia is the leading cause of pneumonia in the ICU and occurs more often in patients with high gastric residuals, although we don't have an evidence-based relationship between the volume and aspiration risk. So again, these are things that are correlated, but I have not yet been able to establish causation. Risk factors associated with aspiration include decreased levels of consciousness, neuromuscular diseases, intubation, vomiting, delayed gastric emptying, advanced age, poor oral care, high gastric residuals, prolonged supine position or laying in bed all day, presence of a nasogastric tube, intermittent tube feeding, and a large diameter feeding tube. Treatment for pneumonia, and specifically aspiration pneumonia, so proper feeding techniques and positioning. So again, it's true, your mom wasn't wrong when she said you need to sit up and you couldn't eat laying down in bed. So proper positioning, proper food and liquid consistency, so these may need to be adjusted based on the speech pathologist's recommendations, small frequent meals, and adequate energy and fluids. Now, should these lung diseases become more severe, the patient may develop respiratory failure. So this occurs when the respiratory system is no longer functioning due to chronic lung disease, such as COPD or cystic fibrosis, or an acute injury to the lungs in the case of ARDS. And so here the patient is likely to need supplemental oxygen, but will typically need mechanical ventilation. Now, ARDS is acute respiratory distress syndrome. So this is not a specific disease. This is not caused by a specific bacterial infection or a specific virus. This is a syndrome or a collection of symptoms caused by some other illness. That includes pneumonia, COPD, aspiration, sepsis, trauma, burns, or a vent-associated lung injury. So again, what we don't know is any of these diseases or illnesses can lead to ARDS, but what we don't know is what that exact tipping point is. So the exact mechanism is not known, but what we see is that in response to cytokines being released from inflammatory cells, we have the production of reactive oxygen species. So conditions that are associated with the development of ARDS are pneumonia, aspiration, inhalation injuries, near drowning, or you may have heard of quote-unquote dry drowning, pulmonary contusions, fat embolisms, pulmonary edema, post-lung translation, sepsis, severe trauma, acute pancreatitis, cardiopulmonary bypass, large amounts of blood transfusions, and drug overdose. For patients with respiratory failure, if they're on a mechanical ventilation or breathing machine, they're going to need enteral nutrition, possibly parenteral nutrition. Again, this is going to be determined based on underlying illness and GI function. So we took a look on the previous slide. So if they had some kind of trauma to the lungs and to the GI tract, they may need parenteral or IV nutrition. But otherwise, we're going to hopefully be using the gut with enteral nutrition. Things to examine, so our body composition, lab values, fluid shifts, medications, and exercise tolerance. This is, of course, after recovery, so how much function do they have in their lungs after hopefully surviving this ARDS and respiratory failure. Again, because we're looking at lung function, we would like to use indirect calorimetry, again, avoiding excessive calorie intake. Fairly high protein at 1.5 to 2 grams per kilogram, with the goal of preserving and restoring lean body mass and respiratory muscle mass. Non-protein calories will be divided between carbohydrates and fat. Enteral and parenteral nutrition, again, we may be using a higher fat, lower carb formula, but there actually is a specialty formula. So we had Pulmicare for COPD. For patients with ARDS, we exclusively use a formula known as Oxepa. Now, once you'll get to taste test Oxepa during your supervised practice, but what it's famous for is it has an incredibly fishy smell and taste. And that's because it's very high in omega-3s to help mitigate the inflammation that occurs during ARDS. Again, avoid overfeeding, monitor fluid balance, and again, vitamin and mineral supplementation with a focus on phosphate, again, being necessary for optimal pulmonary function and normal contractibility of the diaphragm. Nutrition practice guidelines for patients with respiratory failure. Again, a proper screening. Energy intake should be kept at or below estimated needs. Again, we do not want excessive PCO2. Modified enteral formulas such as Oxepa to benefit patients with ARDS. Fluid-restricted formula may be useful in patients with ARDS whose hemodynamic status needs less fluids, and again, monitoring serum phosphate. Depending on the success in the treatment of respiratory failure, patients may be on mechanical ventilation or a breathing machine long term. It may be necessary then to perform a tracheostomy. Tracheostomy is probably most famous if you remember the movie from the 90s, Anaconda, with J-Lo and Ice Cube, in which case, right, there is a incision made in the neck through the trachea, and they insert a pen. Now, in real life, it's a little more complicated than that, but these are also done under medical guidelines in surgeries. So it can be performed for a variety of reasons, such as to bypass an obstruction in the trachea, to clean and remove secretions or mucus and prevent it from entering the lungs, to more easily and safely deliver oxygen when the patient is unable to breathe without assistance, so in which case the tube will no longer be in your mouth, but actually directly into the trachea. And so if the patient's unable to breathe on their own and requires long-term breathing, this patient would be conscious, but then still using a machine to help them breathe. So when you are intubated, you are unconscious with a tube through your mouth down your throat. A tracheostomy, the patient will actually be conscious and awake. So you can see, and in this slide they chose to use an obstruction, but you'll recall that this can also happen for direct trauma or injury to the trachea. So there was an example at USC. A football player was bench pressing and people were horsing around in the weight room, dropping the bar on their neck, necessitating a tracheostomy. So this is still a young person who still needs some help breathing, but again, it's going to have to be placed below the actual structural damage to the trachea. Here are some examples of what's known as a trach collar. Now what you'll see is, so these aren't currently connected except for the infant, which is that those actually will have to be hooked up to the mechanical ventilation or breathing machine. Now, if you understand the anatomy and the function of the lungs and the vocal cords, is that they need air to pass across them. So a person who has a trach will not be able to speak to you. So they're not being rude, but they physically can't make any noise because the air escapes from the trach before it crosses the vocal cords. If they wish to speak to you, you may notice is that they will have what's called a Passimure valve, or they may place their finger over the valve, in which case then they'll be able to speak, but they'll probably have a raspy or a wispy voice. But realize if that person's talking to you, they want to say something to you so badly, they had to give up on breathing for a second. So again, don't be alarmed, but again, they literally will not be able to talk unless they have been fitted with a valve, which is to plug the trach, or they're going to have to manually close the trach to speak with you. So patients with tracheostomies are at high risk of aspiration. They may need a feeding tube, and again, they'll probably be doing speech therapy, so again, looking at the viscosity or texture of the food. And so again, the speech pathologist will determine the appropriate texture and consistency of liquids. Again, I recommend that you make the speech pathologist your best friend in determining the appropriate feeding regimens for these patients. And also, the speech therapist is likely to recommend it, but if not, you should, which is small, frequent meals to reduce fatigue. So when you're having to swallow a certain way, practice a certain way, do certain exercises while eating, these patients get tired very easily, but we still want them to get good nutrition. So again, eating, taking a break, and then coming back to it to ensure adequate, safe intake. We discussed that the treatment plan for some of these diseases is a lung transplant, and so we can replace one or both lungs. This is for patients with end-stage lung disease, and you may see a patient will receive a heart and lung transplant at the same time. Similar to all transplants, this requires lifelong immunosuppression treatment. And nutrition side effects include GI distress, increase in blood pressure from sodium retention, swelling, alterations in blood glucose, and decreased bone mineral density, again due to the large dose prednisone that is common with all transplants. Implications for the transplant itself. If the BMI is less than 17 or over 25, there's an increased risk of dying within the first 90 days of the transplant. Depleted lean body mass is associated with higher death rate or mortality for patients awaiting transplant. So again, we need you to be the right total mass, but also that needs to be quality tissue. So again, we don't want a patient to have too much fat or too little muscle while also not being too large or too skinny. So again, we're going to be assessing body composition versus just weight. So again, a patient may be overweight but with low lean body mass, which would be a very bad combination in preparing for transplant. Calorie needs at 130 to 150% or 1.3 to 1.5 as a stress factor, or 35 calories per kilogram. Protein is going to be 1.5 to 2.0 after the transplant to promote healing. Pre-transplant, we're going to optimize nutrition status with small, frequent, nutrient-dense meals. We may be using enteral nutrition, so if the patient's unable to meet intake needs on their own with food. And then post-transplant, again, we want to promote wound healing, treating electrolyte imbalances, and again, achieving optimal blood glucose control, knowing that because of the high doses of prednisone, it may be difficult. Patients are typically able to eat 3 to 5 days after transplant, so considering that they opened you all the way up, had to work around the rib cage, put in a fresh set of lungs, again, your trachea is being reconnected, that's pretty impressive. And so these patients may benefit, though, from enteral nutrition or parenteral nutrition during that 3 to 5 day period, depending on needs, other comorbidities, etc. Upper respiratory infections. So this is something we have all suffered from, or in my case, I'm sure you've probably heard it in my voice, ongoing for many months. So non-specific to describe acute infections which involve the nose, sinuses, pharynx, larynx, trachea, and bronchi, aka having a cold. Now what you'll see is the pathophysiology is so as aerosol, droplet, or direct transmission, which is how this is passed. So aerosol, if you've ever seen a spray paint can or someone sneeze and you see the light behind it and you're like, that was incredibly disgusting, that is aerosol. Droplet is when somebody who is speaking and you'll see that they may spit and you can actually see the large couple of droplets. And then direct transmission, so again, this would be things, so this could be passed on surfaces, so if somebody wipes their mouth or their nose and touches a shopping cart handle, etc. Or if your significant other has it, then you're likely to get that illness as well. Clinical manifestations: runny nose, coughing, sneezing, sore throat, and headache. Treatment: minimize the symptoms with OTC medications. Again, vitamin C may decrease duration and severity, but will not cure or prevent infection. And zinc lozenges have conflicting results in peer-reviewed studies. And the other major concern is that zinc supplementation can result in copper deficiency, which may actually harm immune function. And the other disease we'll discuss is tuberculosis, or TB, or if you watch old-timey westerns, you may have seen it referred to as quote-unquote consumption. So a disease caused by the bacterium Mycobacterium tuberculosis, and it usually attacks the lungs. Now TB is spread, again, through the air from one person to another through droplets. And the people that are most at risk of contracting tuberculosis are healthcare providers, residents in assisted living or skilled nursing facilities or in the hospital, and those who are immunocompromised. Now, 90% of those who are infected with TB will not develop the disease or the acute infection, right, which will actually damage the lungs. Like any bacterial infection, either you'll fight it off or you won't. But for many people, they will successfully fight off the bacteria. Now, there is a class of antibiotics that are used to treat TB. I can tell you though that it was a very, very long course, approximately 1 year of treatment, and it requires extremely accurate compliance for success. And so TB is one of the few diseases that will actually, in essence, they will put you in medical jail, or what's known as a sanitarium. So there are basically 3 major strains of tuberculosis. You have tuberculosis, you have drug resistant, and XDR, which is extreme drug resistant. In which case, I can't actually cure you of TB, and you are such a danger to the public, we could not handle. So the current epidemic kind of shows you the fact that our medical facilities are overloaded. The problem with XDR is that while COVID may go away after several weeks, XDR does not. And so there is no treatment plan, and so we could not handle the population developing XDR tuberculosis. So if you develop XDR through antibiotic resistance, you may be confined to a sanitarium, or in essence a hospital jail, and you will not be able to leave. Regular tuberculosis, again, you'll be going through this treatment, you'll be asked to use proper precautions, wear a mask in public, possibly, etc., etc. Implications include undernutrition, weight loss, and a famous symptom of tuberculosis is night sweats, fatigue, shortness of breath, coughing up blood, as you've seen in all the movies, and again, being aware of drug-nutrient interactions, so don't consume alcohol with these class of drugs. So these patients may have higher energy and fluid needs. They may require assistance with ADLs, including shopping and preparing meals, depending on when it was diagnosed. And medication absorption is decreased with food. So again, take it 1 hour before or 2 hours after meals. And it does deplete vitamin B6 and interfere with vitamin D metabolism. So these may need to be supplemented. All right, so for our review questions, so the energy need of patients with pulmonary disease are typically A, higher than normal, B, lower than normal, C, the same, or D, depending on the drug treatment. And in this case, they are typically A, higher than normal. Pulmonary aspiration leads to A, cystic fibrosis, B, tuberculosis, C, pneumonia, D, cor pulmonale. And that is C, pneumonia. Respiratory quotient increases with excessive intakes of A, fat, B, carbohydrate, C, protein, D, sodium. And this is B, carbohydrate. Again, this is why we recommend that patients typically with pulmonary disease eat a higher amount of fat in their diet and lower amounts of carbohydrate to decrease CO2 production. 4. Compared with non-smokers, people who smoke cigarettes require more A, vitamin A, B, vitamin C, C, vitamin E, D, vitamin K. And this is answer choice B, vitamin C. Again, this comes from the trial where we were exploring antioxidants to protect us from smoking. Again, you need to avoid vitamin A, beta carotene, but we do recommend that smokers consume additional vitamin C. And number 5, people with cystic fibrosis require higher than normal intakes of A, vitamin C, B, calcium, C, iron, D, sodium. And this is answer choice D, sodium, and this is lost through their sweat, which is containing higher amounts of sodium and chloride. Good luck, and I look forward to speaking with you all on the Zoom session.